So maybe Kerry, if you could lead us off, that would be wonderful.
Sure. I'm Kerry Hamilton. I am an assistant professor at Arizona State University in environmental engineering. I have a background in public health and engineering. So I got interested in QMRA because I thought it was a really interesting framework for putting together information from lots of different fields. And Amanda, maybe
Wonderful.
you want to go next?
Thank you.
Sure. I'm Amanda Wilson. I'm an assistant professor in environmental health sciences at the University of Arizona. And I got into QMRA, I feel like in kind of a strange way, but by show of Zoom hands, has anyone played the game Sims, the computer game? Well, so I was obsessed with Sims growing up in high school. And that was just sort of a side part of my life. I was just so interested in human behavior and like, how did they even gather the data to inform this game? And then in grad school, I started studying microbial risks, and I was like, oh my gosh, we can create simulations that explore human behavior and how that influences risk. And it's like Sims, you know, and it became a way of describing my life to my parents who had no idea what I was up to all day. So that's kind of how I got into QMRA, just this interest in human behavior and an interest in risk. And I tend to be a very anxious person who doesn't like facing risk. So that also was sort of a personal gateway into this topic.
All right, and I'm Patrick Gurian. I'm a professor in civil, architectural, and environmental engineering at Drexel University. And I guess I first got involved in microbial risk assessment because I was working on a water quality project with a collaborator who was very interested in microbial risk assessment. And she kind of showed me some of the tools, and some of the students we were working with led a paper. And then that led to an opportunity to work on bioterrorism as part of the QMRA Center. And it just seems like there have been a lot of really important applications, whether it's biosolids or water in building plumbing systems, where QMRA has been a really useful set of tools to have.
Great. Thank you for the introduction. And I think we do have a nice critical mass. Welcome everyone to our second of the QMRA4 web series. We've had a nice introduction, and we'll let the presenters move through, and you're welcome to use the chat or raise hand if there's something in the middle. And I believe there's some time built in toward the end to be able to ask some questions. I do want to mention that this is a webinar that's funded by the National Institute for Health, and so it's part of the QMRA4 program. So with no further ado, let's hear about describing risk in a QMRA. Thank you.
I'll start us off. So we're excited to speak with you today about a topic that spans a few different aspects of risk analysis. So risk analysis includes both risk assessment and risk management. And, tied in closely with that is risk perception and risk communication. And really, when we finish our risk assessment and figure out how we want to incorporate that information into other elements of decision making, and ideally that's an iterative process, we'll go over some of the main considerations. So whenever we make a decision, we use the results of risk assessments and other evidence to inform our decision, but there are also a lot of uncertainties associated with that decision. Typically, when we want to make a decision, we're not just thinking about microbial risk or a specific element of, let's say, health risk analysis, but rather weighing that with different things like, taking risks in order to create value and innovate in our society, while also reducing risks and uncertainties associated with, let's say, new technologies or pathogens or any kind of hazard. So some of the methods that we'll talk about today that I've highlighted here, things like cost-benefit analysis, as well as using risk acceptance criteria and criteria that might designate an as low as reasonably practicable type of framework. When we make a decision, there's lots of different contexts for this, and it really depends on the level of where the decision is being made, as well as whether it's a peacetime decision used for planning and other purposes, or whether this is a reaction to a crisis situation. And that can really affect the type of process that you use. We all make decisions every single day about our health and our safety and other aspects of our life. And really, as risk assessors, we think about what might be done at the policy level. So how do we take the processes that influence decision-making at the individual level, extrapolate those to the population level, and try to make good decisions? And so an example here of, maybe a more medical type of situation where you as an individual receive some information, but then as a policymaker, you have to think about what is going to work for an entire population. When we think about scaling up in that process, now we're talking about risk governance. So how do we take all the things that we know about our risk assessment and scale those up to make good decisions and policies? And there's kind of two different approaches here. One is a strictly risk-based approach on the left side, where maybe we just use the outputs of a QMRA to inform something like a direct potable reuse treatment requirement, or more of a prevention-based criteria like Mallory et al. Has proposed, looking at different types of alternatives and then keeping that in context and making a decision among alternatives that maximizes the total beneficial aspects or utility of that system. I wanted to do a reality check first, because every day we don't just think about risks, right? We think about things in a more holistic way. And we make concessions all the time in the name of reasonableness and our own personal preferences, especially around Halloween, right? We don't irradiate all of our candy. We like to eat our candy, and sometimes we take a risk. If we think about how this impacts decision-making, we all have an analytical system and a more intuitive or experiential system for decision-making. And our analytical system looks at things like probabilities or actual rates of adverse outcomes. But our experiential system takes all of that information along with things like attitudes, judgments, feelings, and puts them in, I'll call it the feelometer here, and outputs an action or decision on the other side. And understanding what's in that opaque box is really important for us as we try to both tailor our QMRA to a management decision, but also communicate that once we've arrived at an appropriate outcome. Some very well-known work on risk perception in the past has indicated that experts, meaning people who have training in a specific element of risk assessment, versus a non-expert or lay person making the same judgment about how they perceive risk, might be different. So on the right side here, some work by Paul Slovic, where we have an actual number of deaths per year versus a perceived number of deaths per year type of risk. And I've added kind of a line of perfect judgment, where you might have your perceived risks aligning exactly with your observed number of adverse outcomes in a year. And you can see that experts get a little bit closer to that perfect judgment line than the lay public does. But it doesn't mean that the lay public is ill-informed necessarily. It just means that there are a lot of other factors we have to consider. So another paper on the left side here showing that this can be impacted by trust of the group of people providing information about a topic, and the degree of agreement among those people providing that information, which also impacts the trust. Lots of other factors involved for people to perceive risk, like threat to future generations, dread, novelty, uncertainty, and the degree of voluntariness, which of course impacts kind of our perception of things like something related to drinking water, where we don't have a choice of whether or not to drink tap water, but we might have a choice when it comes to a different type of situation. There are a few dominant academic approaches to look at risk perception, not all of which we'll cover today. They're just for your awareness. I'll highlight the psychometric paradigm as a particularly well-known approach for looking at risk perception. Paul Slovic, who I mentioned earlier, developed this psychometric paradigm where on the x-axis we have the degree that something is dreaded or not. So on the right side here, more dread and known or unknown on the y-axis, where things are more unknown or unfamiliar to us. And so the things that might cause somebody to perceive risk to be higher might appear in this right quadrant over here, with the outlier over here, like nuclear power, where folks are both unfamiliar and there's a high degree of dread, especially if that adverse outcome associated with the power plant might impact a lot of people. Once we know how people perceive risk, we can start to ask things like how much risk is acceptable. But based on what I just told you, that's really a moving target. So it's not purely technical, and we can use different types of metrics and risk analysis. We can really place a number on anything and then make judgments, using that information. Things like, is the risk tolerable for the population of interest? Does it merit action, or is a do nothing option really the best choice? And which strategy is warranted? Some of the main strategies for handling risk, we look at risk assessment, which probably folks on this call are more familiar with for QMRA. And there's also other approaches like looking at the complement of risk, which is resiliency, and trying to design systems in a beneficial way, having a dialogue with other types of concerns like cost and uncertainty. In particular, cost is a very important consideration, and under certain regulatory mandates, a cost-benefit analysis must be performed for different types of policy measures. So cost-benefit analysis is really commonly used across a lot of different fields. And the idea is that you can monetize different outcomes or look at direct costs, for example. And there's lots of different metrics that are used, and I'll talk about a couple of them in the next few minutes. The idea here is that if you're familiar with a total cost curve, if we look at the cost of reducing some residual risk, our compliance costs might go up, but our total cost is sort of including all the different costs you might consider for society, individual costs, compliance costs for different institutions. And so there is kind of an optimum point with cost benefit that you can calculate. There are different metrics of cost benefit, and some common ones here emanating from the concept of time value money, where a dollar today is worth more than a dollar in the future. And we can translate dollars into different time periods using things like a net present value calculation, or costs in a particular year accounting for a discount or inflation rate. And the idea is that we want our benefits to be outweighing the costs. Costs are easier to estimate for things that are directly observable, things like hospital bills or lost time from work, missed wages. And so I'm showing an example here of direct and indirect costs in 1981 dollars, so a little bit outdated now, from a waterborne gastroenteritis outbreak. And one thing to notice is that the indirect costs can be quite a bit larger than the direct costs, but they are a little bit harder to put values on. When we weigh costs and benefits, in most cases, we want to choose alternatives where the benefits outweigh the costs. However, even when there is a slight discrepancy, let's say between indirect and direct costs and the direction of that cost-benefit weighting, it might be allowable in different circumstances that we deem acceptable. So, for example, a regulation puts a criteria on a decision, or maybe there's a subsidy that allows us to pursue something in the name of a public health goal. We can monetize risk, and typically we do that in terms of improved health, longer life, looking at versus the cost of a risk reduction, and then in some cases comparing with the dollar per risk figure. And that risk figure could be something like the value of a statistical life, a VSL. And that generally refers to an individual's willingness to exchange their money for a small decrease in risk over a defined time period. It could be a risk of illness or death or something else. In this case, death would be the most appropriate endpoint. If we look at some dollars calculated per life saved, this is in 1995 dollars, so outdated here, but demonstrates a general trend looking at costs for different interventions among different sectors for saving lives. And one thing I'll point out here is that our environmental costs tend to be quite high because of the scale and scope of those types of measures. However, you can look at a ratio of costs per life year saved and see that for some of the lower cost options where it might make sense as a society to allocate funds. Some of you might have just had an ick reaction to what I just presented in terms of putting a dollar value on someone's life. And in case you haven't, got around to seeing iRobot, spoiler alert, I'm gonna, tell you about that movie now. So there's a scene in the movie where two cars go off a bridge and a robot has to pick one to save. And so the algorithm calculates who has the better probability of survival. And the robot chooses to save the adult instead of the child. And the adult who lives looks back, it's Will Smith, and he says 11% was more than enough to save that child. And so I think, as a society, we have a concern that a risk or decision-making algorithm won't appropriately capture our societal preferences, never mind that we can, agree as a society what those preferences are. So it's hard not to react with emotion when that type of topic comes up. But if we're trying to be risk assessors and judge the efficacy of our policies, we have to try. The technical basis for a value of life is really more about investment to avoid a statistical fatality, and it's used in cost-benefit analyses, among other applications, to appropriately value loss of life as a result of different decision-making outcomes. The range of the number that we put on that value of a statistical life is quite large, and so no one values your life more than the federal government. When we want to put public policies into place, often we put a large value on that statistical life because we want to make an argument that, our measures that we're putting into place to improve pollution or to protect us from pathogens are worth it. And that value also is subject to different types of contexts, different locations, for example. If you're feeling discouraged about it, given all these limitations, why should we even put a value on a life or any type of risk at all that is quantifiable or monetized? And it's really because we can't make an unbounded commitment to reducing risk. There's no such thing as zero risk, like the candy irradiation example. So, by trying to judge policies and other decisions by these criteria, we want to value human life in there. And that really comes from, John von Neumann, who was a mathematician in the US, famously made some military recommendations that did not include loss of life as a factor. And that was the inspiration for the movie Dr. Strangelove, a parody of that. So I think, the take-home message here is that it is better to value lives than not when it comes to making policy decisions, even if the number is not 100% agreeable to you. We have many other metrics of losses in utility resulting from health or other adverse outcomes. One of them is a disability adjusted life year, which considers years of life lost due to disability as well as outright. And those disability weights are published by different organizations. An equation is also shown here for how you can do that on a continuous basis. So this is one way in which we can put a value on not just a loss of life, but also, other health outcomes. And we do that so that we can put things in a common currency to sort of make them fungible in economic terms, so that we might compare the outcome of a quantitative microbial risk assessment model, like for probability of illness, with, let's say, the probability of cancer from another model, by converting these into a common metric. And what that means is that, if you lost 5 years of life but were otherwise healthy, that would be $5. But you could also kind of in a weighted average type of way look at your loss of healthy life and equate that to a dolly. And so there's different examples of dolly weights according to loss of health or function. These are also context specific. An example here that I won't go into detail, just from using this in a quantitative microbial risk assessment related to Giardia gastroenteritis, you can derive your own values of these types of dollies and other things, but it can be cumbersome to do. So typically folks will refer to published government or other documents in selecting those values for use in a QMRA. To summarize some of these risk valuation methods, there are many ways in which we can monetize risk and other outcomes, and then we can use judgments that we make about acceptability and tolerance of risk in order to make our decisions. So I'm going to turn things over now to Patrick Gurian to tell us a little bit more about risk-informed decision criteria. So Patrick, you can let me know when to advance.
All right, thanks very much. So yeah, if you could move to the next slide. I love this slide. Kerry made it up, but I get to present it. So you could imagine sort of the bright line approach. So there's the bright red line, and if you're above 10 to the minus 4, that 1 in 10,000, then that's unacceptable and you're unhappy. And as long as you're below that 1 in 10,000, then you get the smiley face and you're happy. Now, just to briefly kind of summarize that 1 in 10,000 in microbial risk assessment is typically annual risk, and it's usually risk of infection. It's kind of Genesis, as I understand it, is kind of decades old at this point, where people were looking at the excess risk associated with the U.S. drinking water supply. So it would be sort of specific to that context, or at least derived from that context of drinking water. And they were able to find about that, 1 in 10,000 annual risk of illness. And then they said, let's add in a safety factor and particularly try to protect vulnerable groups. And so we will make that 1 in 10,000 risk of infection and kind of use that as a benchmark, a goal. And sometimes it's even almost viewed as this bright line between, the smiley face and the unhappy face. If you could advance the slide, please. All right, so here are the, some bright line approaches. Drinking water is basically that 1 in 10,000 that I was talking about, and that has gone on to direct potable reuse. And that kind of makes sense because it is, again, a drinking water application. Then when you get to recreational water, it's a very different application, and the risk standard is much, much higher. Basically on the order of 30 per 1,000 in recreators. And so why is that? Well, you could say, well, it's more voluntary. People have a choice to go swimming in the water. They don't really have a choice about drinking water. It's also, I think, rooted in sometimes we regulate risk to the level that we can detect risk. And so I think this could be due to the epidemiological studies and sort of what risk levels they are able to discern as being reliably above background. And then there's this general idea of 1 microdolly, or 1/1,000,000th of a dolly lost. And I believe that's annually. It's again used by international bodies like WHO. It's a wonderful target. It's a very small target. I would kind of view that as if maybe a de minimis. If something involves less than the loss of, 1 microdolly over a year, then we would probably conclude that it is acceptable. If it's more than that, then maybe we really need to look at the costs and benefits and see whether we can take action or not. Could you advance the slide? Thanks. Okay, so should benchmarks be different in different contexts? I'm going to argue that they should be. And Kerry, if you could just advance to the next slide, I'll try and illustrate this a little bit. So this is Michael Ryan's paper from back in 2013. And so I'll direct you to the right side, figure 1 from this paper. And this is looking at the decision to issue a boil water order. So this is where the public water supply has been compromised, and there's some level of cryptosporidium, and we're trying to figure out, should we just say, it's okay, or should we tell everybody to boil water? And of course, boiling water involves some risk, actually, and it's not perfectly effective, and it involves some costs. So you see, if we tell them, don't boil the water, then there's risk of illness, capital I. And if they don't get ill with probably 1 minus I, well, then you got away with it and there's no cost. But if they do get sick, then there would be some cost of illness, $1,000.20 if you sort of follow the yes branch from illness and the no branch from death. And then if they do die, again, at this point, based on typical monetary valuations of fatal risk, we came up with $7.87 million loss. So then, what about the other option? If you do boil the water, then there's some residual probability of illness. So you would be reducing the initial risk I to a fraction of that. That fraction is Q. So the overall risk of illness would be I times Q. And then you would have the same, basic outcomes there, except now if you die, you boiled water, so you lose the $69
that you spent boiling the water for nothing. So you're even worse off. And again, if you are not sick, then you do have the loss of the $69. Again, taking the yes branch from the boil water order and the no branch from illness, you'd be out $69.25, and that is kind of the impacts of the boil water compliance, the costs of that. So one thing to think about here is that this winds up being very much higher action level. So what you do is you tweak I, and you find the risk of illness such that you are indifferent between boiling and not boiling. And then at risks above that, you would presumably want to boil. And at risks below that, you would not, from a benefit cost standpoint, want to boil the water. It wouldn't produce net benefits for you at the risks below that critical value of I. So basically, that level was about 2 in 1,000 daily risk of infection. So this is much greater than the 1 in 10,000 annual. So it's just a point that the context matters a lot. I mean, if you think about how much you're going risk you're going to tolerate from when you have the option of centralized water treatment, right? You have economies of scale. You're able to do that very well, and you can do that in a cost-effective manner down to very low risk levels. Versus when you're kind of asking people to do this by themselves at home, well, you would only do that when the risk levels are considerably higher. So I think there's sort of a lesson here that, again, when the costs of compliance, when the costs of risk reduction are significant, then you are going to tolerate higher levels of risk. All right, if you could advance the slide. All right, wanted just briefly to touch on something that I'm not an expert on, but that is just the considerations for person-to-person transmission, because this really could change how you feel about benefits and costs. Ideally, you would run a whole infection transmission model that looks at the environmental exposure and all the baseline exposures, and then you would run that model with just the baseline risk, and then taking the difference, that would be the attributable risk, how much risk is associated with that environmental exposure. There are cases where people are actually able to do that. In other cases, people are sort of doing their best to estimate a multiplier for additional cases. You know, if I get one primary case from this exposure, then I'll get, 20% chance of getting another case or something like that. So you just take your primary cases and multiply them by a factor that's usually based on what you've been able to find from the literature. So I think in theory, we'd certainly want to do option 1. I think there are cases where option 2 is probably acceptable, particularly cases where the secondary cases are likely to be limited in number. We're not really looking at igniting an outbreak. All right, if you could advance the slides, and now I'm going to pass it off to Amanda. Thanks so much for your attention.
All right, great, thank you. So now I'm going to pick up the baton and talk about some examples of that bright line approach, and then I'll talk through what are some other approaches we might consider, or what are some, I guess I'll leave you with some questions at the end of this to think about whether these approaches are the right way moving forward, or how we might reevaluate this as people in the QMRA field who will be advancing it. So one of the examples of that bright line approach, and I think Kerry mentioned this in her slides as well, is in the context of direct potable reuse. So this was a paper where they were looking at the required virus and bacteria log reductions, and also log reductions for Cryptosporidium and Giardia, and what the log reduction would be needed to achieve that 1 out of 10,000 annual risk of infection. So they have distributions of different risks. It's kind of a complicated figure to interpret, but basically the colored bars are different options for log reductions for Cryptosporidium and Giardia, and then they're coupling those with different options for virus and bacteria log reductions. So in this paper, they discuss how a minimum of a 14 log reduction of virus and bacteria would be needed to achieve that 1 out of 10,000 risk target. But you can see how you could model a lot of different scenarios and then look at how do those scenarios compare to this threshold? Are we okay with a few of our, really high-end infection risks that we're estimating be at that line or above? What percentile of our distribution of infection risks are we okay being above that line? Next slide, please. An example from my own work is we're often looking at contexts outside of water in some of the work that I'm doing, and we really don't have a lot of good guidance on what an acceptable risk value is. So for better or for worse, we use that 1 out of 10,000 risk value, not necessarily as a firm target, but just as a comparison point and seeing how we measure up against that. So during the pandemic, there was a lot of debate about what are the risks attributable to, fomites versus aerosols versus droplets, and then big discussion about, well, droplets are aerosols and terminology arguments. So we just took on that fomite piece and we said, okay, well, we have fomite transmission models. Let's take a look at what different risks would be for a single touch with a contaminated surface, followed by a single touch to facial mucosa. And so we looked at what are some different log reduction ranges for that we might be able to achieve on surfaces. And we also looked at, things that were uncertain at the time, like how much viral bioburden might we have on these surfaces? What percent of genome copies are we going to assume is representative of infectious virus? And then we just looked at, okay, how much reduction on surfaces would we need to achieve a 1 out of 10,000 target for a single touch with a surface, or a 1 out of a million risk target? And we found that we really don't need that much reduction. We have products that can achieve these reductions in a single application. And it's funny, that 1 out of 10,000 target, the CDC ended up taking this paper and a few other risk assessments that were using similar models and showing similar results that risks from fomites were really low. And they published this scientific brief saying, in general, it seems that risk models are showing that risks from fomites are less than 1 out of 10,000 for a single touch. And of course, the science community and the media got a hold of that. Oh, less than 1 out of 10,000, that sounds so small. I was talking to a psychologist who studies decision-making, and he was saying that in general, humans struggle to imagine less than 1 out of 100. So once you start talking about 1 out of 1,000, 1 out of 10,000, it seems unimaginably small. When you multiply that by the number of people in the world or the number of times you touch a surface, that can start becoming more meaningful. But just to give you context for how the public took on this message, they were like, wow, fomites less than 1 out of 10,000. And that became a really great piece of, an argument that aerosol scientists could make for, look how small the risk is from fomites. Let's focus our efforts on other transmission pathways. Next slide, please. Here's another example from Kerry Hamilton, who's on the call. Hopefully I don't totally misrepresent her results. Next slide, please. So here's a great example. This is just one figure. Kerry has a lot of other great figures in that paper, but they're comparing different risk outputs, annual infection, DALI to that 1 out of a million, annual infection to 1 out of 10,000, and then looking across a lot of different types of fixtures. So conventional toilets, water efficient toilets, conventional and water efficient showers, conventional faucets. And these were median outputs from a distribution of risks that were estimated. But this gives us insight into what concentrations of Legionella pneumophila in the water would be needed to meet that risk target. Next slide, please. I wanted to end with a few thoughts, mostly philosophical, to get you thinking about, is the current approach the right approach? Are there other approaches that we can use to advance risk assessment in terms of setting risk thresholds? So I've been doing a lot of reading. These are 3 books that I just wanted to highlight that I highly recommend, and I'll just kind of pull a few ideas from a few of them. Next slide, please. So this is from Paul Slovic, who Kerry mentioned earlier, And I want to question the definition of risk. I think in risk assessment, when we talk about risk, we're often equating that with the probability. But the general public typically defines risk in a different way, and that's not necessary, and it's not necessarily wrong. And I think it's something that we have to embrace in risk assessment. And I love this quote. In this view, risk does not exist out there independent of our minds and cultures waiting to be measured. Instead, human beings have invented the concept of risk to help them to understand and cope with the dangers and uncertainties of life. And at the very end, even the simplest, most straightforward risk assessments are based on theoretical models whose structure is subjective and assumption-laden and whose inputs are dependent upon judgment. So I think it's always good to approach risk assessment as a risk assessor with some humility, right? And thinking about what are our own biases that we might be bringing to that process in our own cultures. Next slide, please. I'm really enjoying this book by David Resnick. He's a bioethicist at the National Institute of Environmental Health Sciences. And the focus of the book is on the precautionary principle, but he has great chapters on overviews of decision theory, moral theory, and talking about the ethics of approaching decision-making, especially from the perspective of experts who may be making decisions on behalf of other people. And a key concept that I've been really stewing on for a while is this idea of reasonable versus rational, and what's the difference. When we taking a risk that is reasonable, it typically implies assumed morality. Whereas rationality or a rational decision is something we make to achieve some end, and it doesn't matter what we do to achieve it. And there's a really dramatic example he gives in the book that's a little shocking, but it illustrates the point. And he says, let's say a lover finds that their lover is cheating on them. It would be rational to kill the person that they're cheating on them with, because that would achieve some objective of revenge, or justice. But is that reasonable? No, because us as a society generally agree that murder is wrong as a moral principle, right? So this idea of reasonableness and rationality is really important in public health, because what we might think is reasonable, the public may not think is reasonable, depending on a given culture or community. And we have to remember that rationality is value neutral. Next slide, please. And going through all these decision theories and morality approaches, one of the big takeaways is that decision theory doesn't always give clear guidance on how we should approach risks. Morality doesn't always give us a clear guide. And David Resnick in this book gives example after example where even the most systematic decision theory that's supposed to generate a decision for you, there's some exception that appears unreasonable. And then the theorists go, okay, well, we'll make an exception, we'll tweak the rule. And eventually they've tweaked the rule so much that the theory doesn't even hold anymore. And so in between this space of morality and decision theory is where the precautionary principle exists. I think a lot of people in risk assessment think they know what the precautionary principle is, and they are right, but there are many definitions. I think that's something we have to acknowledge. And he goes through a lot of different definitions from different bodies that have meaningful differences. But the main takeaway is that we're always trying to address, which involves either avoiding, minimizing, or mitigating a harm. Next slide, please. This book is really great if you want to understand what are some of the mental shortcuts that humans make when they're assessing risk. Just some examples, there are a lot more in the book, but the representative heuristic, where the similarity of a sample statistic to a population parameter does not depend on the size of the sample. So there's a lot of examples where people will use a stereotype. They'll describe a person and say, are they more likely to be a librarian or I'm trying to think, a school teacher or whatever. And someone will say, oh, they're more likely to be a librarian because they're shy, or, they'll use some kind of stereotype. And then the result is that, well, there are a lot more teachers than there are librarians. So the probability that they're a teacher, despite their description of their personality, is higher. There's a lot of examples like that in the book. Other things include things like misconceptions of chance, where you're expecting a certain sequence of events to, quote, appear random. Next slide, please. But a big takeaway from this book is that experts are humans. Researchers use heuristics and biases too. And I just put one quote here, but there are many examples throughout the book where, you know, the most highly trained psychologists and statisticians are given the same tasks as people without that training, and they fall victim to the same heuristics and biases. So one of the big takeaways from this is, you know, as experts, we may have different judgments about risk, but we can still have logical flaws or be taking shortcuts that influence our view. And that's something that we need to consider when we're approaching a risk management process. Next slide, please. This book I love. I can't put it down. It's in my office right now. I'll show you. I have it here with all these little sticky notes in it. I'm loving it. It's from 1995, but the ideas are extremely relevant today, talking about risk trade-offs. And I wish there was more time to talk about it, but they have different strategies for plotting and thinking about risks where we may be introducing an intervention that increases a risk in one outcome that we didn't intend. An example that I'm studying right now is cleaning and disinfection, and it's risks for asthma in healthcare workers. Next slide, please. Some other aspects of decision-making that we wish we could get into with more depth include equity and justice aspects. You know, how do we involve communities who are going to be facing the risks that we might be managing? Another food for thought is restriction of feasible alternatives versus regulatory or legislative mandates. Next slide, please. So our take-home messages are that risk management and governance are informed by risk assessment. Risk management involves making a decision, often weighing costs and benefits. And to weigh and prioritize trade-offs, we must value risk, and there are several methods to do so, typically from the field of economics. And there's contextual information such as justice and human rights that need to be considered and incorporated into current and future approaches. And I believe that's our last slide and some references. Thank you.